Okay, good afternoon, everybody. Thank you for joining us today. I am here to present, well, first of all, my name is Chad Worley, and I am the physician liaison for Lurie Children for the north suburbs, and the north suburbs, northwest, and north side of the city. But more importantly, I am here to introduce you to our newest ophthalmologist, Dr. Jennifer Rossen. She comes to us from the University of Texas Southwestern Medical School, where she did a fellowship for Lurie Children's. She just finished up, and now she is an attending physician here. And speaking of, she sees patients at the main hospital and at our Lake Forest facility. And our division of ophthalmology is a world-class treatment and care center for a full range of pediatric eye disorders and eye trauma and vision problems. The division consists of 10 board-certified ophthalmologists with fellowship training in pediatric ophthalmology. Last year, the division offered care and consultation to almost 18,000 patients, and we performed 829 surgeries. We have ophthalmology at the main hospital, Lincoln Park, Lake Forest, Northbrook, New Lenox, and Westchester. And we are really pleased to announce that the Division of Ophthalmology has increased appointment times, especially at our outpatient clinics in Lincoln and Lake Forest, Northbrook, Westchester locations, due to wide restructuring, and has almost doubled the number of available appointments. And these appointments can be seen within a week, in some cases the same day or next day. So as always, if you can call 1-800-KIDS-DOC or submit a Lurie Ophthalmology service request via Epic, we will get that appointment scheduled for you. But without further ado, you don't want to hear me talk anymore, so let me bring you over to Dr. Jennifer Rossen and take it away.
All right. So hi, everyone. I'm Jen Rossen. I'm really excited to be joining Lurie's Department of Ophthalmology after completing my fellowship here and my maternity leave with my second daughter. I'm originally from the northern suburbs of Chicago. I'm enjoying being back in the area. Like Chad was saying, seeing patients in the northern suburbs and downtown. My talk today, it's a little review on amblyopia and some updates on ongoing research and some new treatment modalities. So amblyopia is a low vision that occurs in one or both eyes due to abnormal visual development in childhood. It's actually the leading cause of vision loss in children. It's treatable in children, but irreversible once patients are outside of the ocular developmental window. So some causes of amblyopia include anything that causes blurry vision during ocular development can lead to amblyopia. We usually think about ocular development occurring up until someone is 8 or 9 years old, but we have shown that treatment can still be effective up into the early teenage years. One eye often becomes amblyopic when the fellow eye is preferred. And reasons that may cause blurred vision during ocular development include refractive errors or needing glasses, strabismus, or structural eye problems causing a deprivational amblyopia. The photo in this slide is a picture from the studies of David Hubel and Torsten Wiesel from the 1960s. What they did was they sewed one eye of a kitten shut for various periods of time, showing that vision impairment from early on in life left long-standing vision problems and actually changed the makeup of the brain and the visual pathways themselves. They won the Nobel Prize in 1981 for this research on understanding the critical period during ocular development. They showed that when the eye of a kitten was sewn shut early on in life, that eye never was able to develop good vision as the kitten got older, and that continued on and helped us understand more about amblyopia and treatment of eye disease in children. So one common form of amblyopia is refractive amblyopia. High refractive errors, including myopia, hyperopia, astigmatism, can cause amblyopia in one or both eyes if not treated. The primary treatment is usually refractive correction. In children, glasses or contacts are usually the treatment of choice. If there is significant anisometropia, or a significant difference in the prescription between two eyes, this can lead to a binocular amblyopia. This usually requires treatment in addition to glasses, such as patching, but not always. Sometimes just glasses are enough. Kids often don't tell us that they can't see well. Either they don't realize it or they just don't tell their parents. For instance, before I got glasses in 3rd grade, I never realized that there was a piece of paper that was taped up on the chalkboard at school, and it always had the homework assignment for the day. I just thought it was a blank piece of paper, and I often missed homework assignments because of it. So, you know, really showed for me that having this proper refractive correction is critical for kids with refractive errors, not just to see well, but to succeed in school and help with their eye development. Another form of amblyopia is strabismic amblyopia. Unlike adults, when a child's eye crosses in or turns eye, the brain adapts by shutting off that eye to prevent diplopia. If your eye were to develop an eye crossing in or out right now, we would see double. And if the eyes alternate wandering equally, so the right eye wanders as much as the left eye does, then both eyes usually receive equal visual input and no amblyopia develops. But if one eye deviates more than the other, then that eye is shut off more than the fellow eye, and that's when amblyopia develops. Strabismic amblyopia usually requires treatment in addition to surgery, such as glasses and or patching. And sometimes glasses and patching are enough, and surgery is not warranted. So deprivational amblyopia occurs when there's a physical barrier blocking the visual access, which inhibits visual development. So some examples of this are cataracts, ptosis, such as from just congenital ptosis, tumors of the eyelid or orbit, like capillary hemangiomas, or even chalazion can cause amblyopia. Corneal clouding, trauma, or even ocular tumors such as retinoblastoma are other causes of deprivational amblyopia. This form of amblyopia is usually very dense and can be difficult to treat. The prognosis is variable because there is something intrinsically wrong going on with the eye at the time. So I usually give parents a guarded prognosis, but we always try. So we don't always know if a patient comes in with amblyopia from ptosis, we don't always know how much is the vision decreased because the eyelid is blocking the pupil and how much is the vision decreased from amblyopia. So we always treat the amblyopia in addition to treating the underlying cause, and tell parents that we're not sure, but our goal is to patch until we no longer see improvement. So some signs of amblyopia include one eye turning in more than the other. So this can be a sign of strabismus from an unrelated cause, or it can be due to a sensory cause. So a sensory esotropia often develops in children who do not see well out of an eye, usually because of a structural abnormality. So this sensory esotropia can exacerbate and deepen the amblyopia from the underlying structural problem if not treated. Poor visual behavior is a sign of bilateral amblyopia. And when patients have poor vision due to structural abnormalities very early on in life, often from birth, if not corrected, they can develop an nystagmus, and essentially their eyes are searching for a visual input. Unilateral amblyopia is more likely to be asymptomatic and difficult to identify without vision screening. Unless the child inadvertently covers one eye for some reason, they may not even realize that the vision is decreased in one eye because they can still see well out of the other eye. So amblyopia is often picked up by vision screens at school or well-child checks, as children are often asymptomatic or do not complain. Photo screening devices can be used to identify potentially amblyogenic refractive errors, and complete eye exams are then performed to confirm the visual acuity and determine the etiology of the blurred vision. So the first step in treating amblyopia is to treat any underlying condition. So for refractive errors, that's usually glasses or contacts. For an orbital or lid hemangioma, right now, the mainstay of treatment is oral propranolol. That's usually done here at Lurie by dermatology, and we co-manage with them, and they've had great success with that. If there is a lesion that's causing the eyelid to cover the pupil in a child during their developmental years, so before 8 or 9 years old, that can cause amblyopia, and so that would need to be removed, such as a chalazion. We can either excise it or start treatment with medications. Ptosis that's causing blocking of the pupil needs to usually be repaired to lift the eyelid. We remove any visually significant cataracts, and usually the children afterwards require contact lens treatments. If they're very young, older, we can place an intraocular lens at the time, but still need glasses after. And strabismus surgery is ideally done after treating amblyopia first. I always, discuss with parents that, the treating these causes of amblyopia is just the first step in improving the vision, and afterwards is when the real hard work starts of treating the amblyopia that has occurred because of the structural problem with the eye. It's best to start as early as possible, but studies have shown that starting a treatment for amblyopia even as late as 14 years old can prove beneficial, especially if the patient has never received treatment before. So patching is still our mainstay of treatment now. We patch the better seeing eye while the patient is awake with the proper correction to force the brain to develop the visual pathway in the weaker eye. Some recent studies have shown that shorter patching times are as effective as the longer times that were previously prescribed. So for severe amblyopia or vision of 2100 or worse, patching for 6 hours is proven to be equally effective as full-time patching. And for moderate amblyopia or vision 2040 to 2080, 2 hours of patching is equal to 6 hours of patching. And that's a lot easier, not easy, but easier for the parents and the patients to comply with. It doesn't matter if patients are doing near or distance activities while patching, but the patient must be awake. Even though it's easier to patch a sleep child, it's not helpful then. So an option that I consider if a patient has failed treatment with patching due to compliance issues, or if a patient's hyperopic and trying to adjust to their new spectacles, is atropine penalization. So 1 drop of atropine on Saturday and Sunday in the better seeing eye can penalize it by inhibiting accommodation and causing blurred vision in the better seeing eye. The effects of the drop can last for 1 to 2 weeks. So it's helpful in that 1 drop can last for a while, but it also, I always warn parents about that so they don't inadvertently dilate their own eyes for 1 to 2 weeks. Since atropine penalization works by inhibiting accommodation, it's less useful for patients who are myopic or nearsighted because they can still see well even if they aren't able to accommodate close. So due to the systemic side effects also, I'm wary of using atropine in children with higher risk comorbidities such as cardiac issues. So another option for patients with glasses are to blur or cover the lens of their better seeing eye. A Bangor foil is a blurring adhesive that attaches to glasses and it can be placed on the lens. There are also forms of patches that can be slipped over a lens. Sometimes patients are more likely to comply with this treatment, and this is if the patient already has glasses, but it's easier to cheat around the occluded lens, so it's not always as effective as an adhesive patch. There is recently a lot of growing interest in evaluating binocular treatments to see if they are effective at treating amblyopia. So these are often games that use both eyes and require the participation of the amblyopic eye to work. So what they do is they provide a high contrast or high luminance input to the amblyopic eye and a low contrast or low luminance to the fellow eye. The excitement behind these treatments are that they're more fun, so maybe children will be more likely to comply with it and can potentially help with binocular development to help improve depth perception that isn't done when a child's patching. As of right now, there's no level 1 evidence to suggest that the current treatments that are out there are as effective, but there are still ongoing studies to evaluate them. There's an upcoming trial as well. It's a multi-site trial that's evaluating a surgical refractive correction to those children with amblyopia that have failed initial therapy or had compliance issues. So the trial is giving a laser treatment or PRK for patients who do not wear their glasses or contact lenses. So our department at Lurie is currently enrolling in 2 amblyopia clinical trials. We're evaluating simultaneous versus sequential treatment of amblyopia with glasses and patching. So currently there's no consensus on when a patient comes in with amblyopia due to a refractive error, do I give glasses first and then wait to see if the vision improves, and if it doesn't improve enough, then give patching, or do I start glasses and patching at the same time? So this study is a randomized controlled trial, putting the 2 head to head to see if simultaneous or sequential treatment is better, or if they are equivalent. Another study we're enrolling in right now is a binocular treatment with an iPad game. So really the most important part and the most difficult part of amblyopia treatment is patient compliance. So children, no matter what, don't like having their eye covered, even if they can see well out of the other eye. But for amblyopia treatment, we're asking a child to patch their better seeing eye so the world around them is blurry when they're patched. It's very difficult, but I stress to parents and to patients about the importance of treatment and long-term consequences of non-compliance. I explained to parents and children that we have only a small window for us to improve the vision in their amblyopic eye. And I like to compare it to exercise for their eye. I tell them that when they run, they make their legs stronger, and it's the same with patching. When they patch, they make their eyes stronger. Other ways to encourage treatment is with positive reinforcement. There are reward charts that are available online and at stores where patients can place their patch on a chart after they've used it. It's like a calendar chart. And then once they filled up their chart, their parents can give them a reward. I also encourage parents to allow patients to do favorite activities only with the eye patch on, such as a favorite video game or something they really like to do. Although I don't recommend that they do any activity that can be dangerous if the vision in the amblyopic eye is so poor. So for instance, physical activity or sports, if they're playing baseball, but the vision in their amblyopic eye is 2400, it may not be a great idea to do that at the same time. But whenever a patient comes in with improved vision from patching, I like to celebrate the achievement with the patient and their parents, and tell them what a great job they've done, and reinforce that way as well. So here are my references, and this is my contact information. Please feel free to reach out to me on my cell if you have any questions about the presentation or anything else. And thank you so much for your time and for being here.
This was a great presentation. Thank you, Dr. Rossen. So as we let our audience prepare some questions, just a few for you. So when is the best time for, if they have an idea that something's going on, should they contact you right away at their office, let's say at a well visit? Should they just go ahead and throw in a rapid connect or in-back message to you, or should they just make an appointment? Maybe it's something that they'll see that maybe they can look at on their own. Any suggestions there or feedback with that? Because that's a question we get a lot.
Yeah, you know, we have some newer decision trees at the kids doc, but certainly if anyone's concerned about a patient, especially done a vision screen and one eye's 20/30 and the other eye's 2400, feel free to send me a message if you want to get someone in quickly, and I can make sure that we get them on the schedule for that week, or as soon. Usually I have appointments available the same week, so we can do something like that. But I'm happy, or you can even reach out to my cell or send me an in-basket message is totally fine.
Excellent. Well, thank you. So a question did come over and says, what do you do if visual acuity improves, but eye continues to cross?
So that's a good question. Yeah. So that's the best point actually to then consider doing muscle surgery at that point. So once we want to get the vision as equal as possible before considering surgery for strabismic amblyopia, because the surgery actually takes better and lasts longer if the vision in both eyes are equal. So if the vision in both eyes are equal and we've exhausted our options for glasses, sometimes some types of crossing, we can try a bifocal or prescribing more stronger lenses. But if we've exhausted all options and they're still crossing, or there's exotropia with glasses and patching, that's when we consider doing surgery to move the muscles. And that we do. So I do that at Northbrook and also downtown in the city. It's a pretty quick operation for the family, and it's a same day, so they go home that same day afterwards and usually see improvements as soon as the next day.
Great. That's outstanding. You know, with that in mind, what's your telemedicine availability?
So I have telemedicine availability every Thursday and can sometimes fit in on other days as well. So I have right now my Thursday mornings are telemedicine. So I definitely have availability for that too.
That's excellent. I'm sure that's very helpful for a lot, especially in your area. So question came through. What is your opinion on developmental optometrists and or vision therapy?
It's definitely a somewhat of a controversial topic. I know the American Academy of Ophthalmology's take on it is that there really isn't level 1 evidence that it has shown to be effective in treatment, and I know it can be very but there are definitely some people who feel like it's definitely worked for them. So if I get this question a lot from parents or from other therapists asking about should we consider vision therapy? And to be honest, that's not something that we get trained on in ophthalmology training. But I usually say it's not likely to cause problems, but it's not something that I'm really familiar with or have, our academy doesn't show strong support of it. So it's not something that I usually refer to. There are some instances where some kinds of exercises for certain types of exotropia do work, like a pencil push-up, but usually I don't refer for that out for that. But there's definitely some individuals who feel like it's helped them. But another thing to consider is that it's not usually covered by insurance. So that's something else that I discuss with parents.
Okay. All right. Well, thank you for that. I don't see any other questions popping in, and we are getting close to the half-hour mark. So at this point, if you don't have any more questions, anybody, I just wanted to thank you all for joining us today and remind you that this session is being recorded and that I will be sending the link out to you and to your colleagues. But I encourage you to share this with your colleagues so they get to know Dr. Rossen a little bit. And again, to remind you that due to restructuring of how we do things in the department, we have freed up appointment time. So we have availability for folks like Dr. Rossen to see your patients, and hopefully well visits are going particularly well for you guys right now. I know you're not seeing a lot of sick patients, so with your eye exams at your well visits, Dr. Rossen's available for you. So again, as she had mentioned, she could be reached at clinic at 312-227-6180. Her cell phone was available for you at 847-975-8880. And she can be reached by email at jerossen@luriechildrens.org. And with that, Dr. Rossen, would you like to add anything before we leave?
Oh, that's great. Thank you. It's very nice to meet you all, and feel free to reach out with anything.
Yes, thank you. And if you are interested in a one-on-one specialist visit where I take Dr. Rossen to meet you at your practice, just reach out to me on the side and I'll be happy to set that up as well. But with that, I'd just like to thank you one more time and have a great afternoon. Have a great day, everybody.
Thank you.